No, that's fine. I can do this. So what I wanted to share actually is a project that we've done in Nigeria that actually is based on a framework, which is the more important thing for me, is the framework that we did it. But for you to understand the framework and what we try to do in Nigeria, I wanted to go over what the issues were with PMCT in Nigeria at the time, which is still haven't changed that much. But in 2003, when we started our project in Nigeria, this is how things look like. Nigeria at the time, as a single country, accounted for 26% of all new childhood infection globally, with 51,000 new infants being infected with HIV every year. So it was no surprise that there was no way we are going to an AIDS-free generation without Nigeria, something happening there. A lot of the issues where there were low HIV testing among pregnant women. As of the time, Nigeria's testing was about 16% of the pregnant women in Nigeria actually tested for HIV. If you look at that, of those who actually tested for HIV, only less than 4% of those children who were exposed get early infant diagnosis. So people have had different reasons why this happens. There are studies that show that when women in Nigeria, pregnant women in Nigeria, are offered HIV testing, that they accept it up to 80 to 90%. So I don't think the problem was refusal, as might be in other places. The whole idea that the challenge was there is poor access to testing, because initially all the testings were done in health facilities, and there were many regions in Nigeria that did not have any health facility. It's a big country. It's 180 million people. It's 33 states, and it has 774 counties. So it's a huge area, and not all of them do have a health facility. But majority of the HIV program was put the same way we have it in the US in health facility, and that was the biggest challenge. When they do get a chance for them to get tested and positive, there is always a delay, the biggest delay being in terms of linking them to actually care. Getting those antiretroviral therapy during pregnancy and being able to achieve that reduction that we all look for. So if you think about it also, there are less than 50% of deliveries in Nigeria occur in health facilities. So there are all those three opportunities you have to reduce mother-to-child transmission. There was problem at each point. One is that you have to be able to diagnose them early, and you're doing only 16% of your testing. When you actually diagnose and find them, you have to link them and then retain them in care. You have then less than 30% of them receiving therapy, and then you have then less than 50% delivered in the hospital. So the cards were stuck against in various ways. What we thought about doing in Nigeria was actually a little bit of a challenge to things. It happens to be a year that I was spending with the Secretary for Health in DC as a Robert Wood Johnson Health Fellow. And I was doing my project in Nevada. I run the HIV program for Las Vegas and the Southern Nevada County. We put in a HIV program there in 2007, and we have not had any child go through our program that's been infected. So here was I sitting with the Secretary for Health in the room, and Nigeria kept coming up. And then she couldn't resist it and said, "You're from Nigeria?" I wanted to say no, but I couldn't. So I said yes, and she said, "What's going on?" I said, "I don't know. I left Nigeria 25 years ago. I really don't know what's going on." But every day at meetings, global meetings, Nigeria come up. The issue was that they were spending a lot of money in Nigeria, and if you were spending all that amount of money, close to $450 million, and you are getting 1.6% of testing, it wasn't a good return. So she really challenged me to try to go do something in Nigeria, and I sheepishly agreed. But I didn't exactly know what to do, because in Nigeria at the time, there were a lot of people that were working in Nigeria, from Harvard, from Hopkins, from Vanderbilt, from everywhere. So it's not for lack of people who are smart. So I went to Nigeria and kept asking them, so what is the problem? Why is it 16%? And people gave me different reasons. But one reason that kept stuck, that was funny kind of, is that they told me they can't find the pregnant woman. And I'm like, so I make fun of it. I say, well, they can't find the pregnant woman. But the reason they say that is actually in the hospitals where they have, if you actually look at HIV testing among those who came to the hospital, is close to the 80% that we talked about that they received it. The challenge is being access to the hospital, because some of them will come to the hospital, we notice one-time register, in the hospital just in case they have problem, then that's the last time they come to the hospital, unless they have a problem with delivery. So they go back and go to traditional birth attendants and they stay there. The only reason they come to the hospital to register is in case they have a problem. So if you don't catch them that first time, that's it. You miss them. So there were a lot of those issues that we come up. So it happened that a friend of mine who's a bishop, and he was here with me, and he said, I was getting an award actually in San Francisco by the American Academy of Pediatrics for our program in Las Vegas. So he was there, and he was so excited that I found a cure for HIV in Las Vegas, and he asked me, so why are you not doing that in Nigeria? So I said, they can't find a pregnant woman. So, so he said, well, why don't you come and I'll show you the pregnant woman. So I said, okay, again, I agreed. So I went to Nigeria and then went to church with him. And he said, well, if you're pregnant here, why don't you stand up and come to the altar, let me pray for you. So you could see people that you didn't even know. So in Nigeria, culturally, you might relate to this. When I moved to Nigeria with my wife and to the US, and when my wife got pregnant and called her mom, the first thing her mom told her is not to tell anybody. So when you are pregnant, you don't tell people because, you know, the witches and the wizards can take over the baby, and, you know. But here, you know, you get pregnant, you put it on Facebook for everybody to see. So things are different. So usually you know a pregnant woman in Nigeria only when it can no longer be hidden. But here we saw something that was different, was pregnant women who you couldn't obviously identify coming up for prayers because, again, that's what they wanted. So we had a lot of them coming there, and I whispered to him, can you ask for the men? So he said, oh, yeah, if you are the one responsible for this, why don't you stand by your by your woman? And then slowly the men started coming behind them, the women. So I flew back, and on the way flying back, I was excited because I think I see somewhere we are going to find. Remember, the main problem was how do you find a pregnant woman? Because we have two things. We have HIV testing percent of 16%. We have HIV testing acceptance of 80%. So we were thinking that it's only if you offer them that they will accept. That wasn't the problem, but it's how do you offer them to them? So on the way back, we started to think, okay, we'll find out how we'll find them, but how do we actually put in a program to offer them the testing? So that's when the experience back in the US actually became very helpful. So the question was, when we couldn't get people to go to their physician to get the flu shot, what did we do here in the US? So we put them in Walmart, we put them in Walgreens, we put them in CVS. The reason we put those things there is because it's almost everywhere. It's widely distributed. People go there consistently for whatever they want to buy. They have a neighborhood. So we decided, what is it in Nigeria that is the CVS, the Walmart, and the Walgreens? And when we went back to Nigeria, of course, you're not going to find the Walmart, CVS, or the Walgreens. But we started driving around all the communities. You wouldn't believe this, but we went through with the bishop almost 50 different communities, trying to find out something that was consistently around. And in the area we went to, it was a church. So we would go to a community that had 12 churches and no health facility. So, and it was consistent. There was no community we went to that did not have at least 2 churches. The strongest was the Anglican church and then the Catholic church. So those 2 were there. The second thing that was remarkable is that the church was actually sometimes the best building in the whole community. So, and these are community built. So you can see the kind of community investment that they do in this place. So we came back and said, you know, we think that the church will be really a very good place to put in an intervention. So now we think we have a site. Now we think we know how to find the pregnant woman. And the rest of the thing is, how do we integrate all of this into a program? Then we came back to our experience in the US. So, and I relate this so that you can think of how we're trying to make this an intervention that is feasible, that is culturally acceptable, that is sustainable, and that is actually will be transformational, different from what is being done in a way. So we were thinking of our program in a fast way, that they have to meet all the criteria for fast. So one of the things here also is that when my wife got pregnant, so it happened that I am actually using a lot of my experience also. My wife got pregnant, and we had about the baby shower. So her friends threw a baby shower for her. The baby shower is not a program in Nigeria. It's not cultural in Nigeria. Again, Nigerians do not celebrate pregnancy because a lot of pregnancy do not end up in a child. So they celebrate childbirth, not the pregnancy. But here in the US, we celebrate that because almost assume if you get pregnant, you have a baby, right? So, but we say, how do we integrate that? In the US here, the baby shower is done, sorry, it's my son's Tom and Jerry. That they have to, and Subway stuff and minions that they load on my phone. But, but, but the thing that happened is that if you go back to Nigeria, it's a communal. So you are not going to have individual people doing baby showers and things like that. So our thought process is, why don't the church actually organize a baby shower for everybody that's pregnant in their program? And then during this program, we can actually put in an intervention, which is simply a health fair. That's the thing. Then the second part is that since they already celebrate a baby reception and they already have infant baptism that correspond about 6 to 8 weeks, which happen to be the same time that you do your early infant diagnosis. So we try to put that. So that's essentially what the Healthy Beginning Initiative is. You probably see in the name Healthy Beginning Initiative, there was a concerted effort to make sure that HIV do not appear there. That was not a mistake because stigma still remains the biggest barrier to Nigeria actually reducing mother-to-child transmission. It is the biggest problem. It's a big problem to the extent that it challenges even this infrastructure we have, and I'll tell you a little bit about it. So the three platforms we had was to use what the bishop had, which is the prayer sessions. When the bishop calls a pregnant woman and comes up, he doesn't pray for their HIV, not to have HIV. He prays for them to have a safe pregnancy and a safe delivery. So we actually, in most cases, the bishop said, your problem here is that you might have women who are hoping to become pregnant come up for prayers. So instead of not having all the pregnant women, you have the pregnant women and much more. So, and we didn't complain because anybody that was coming up there hoping for a baby will be in the childbearing age. So initially we had wanted to do a pregnancy test. We said, but why? If they are not pregnant now, they'll be pregnant later. So why don't, if the only woman that comes up there and said, I'm pregnant, we assume they are pregnant. We didn't, so we removed our pregnancy test because that means that, they are childbearing age, so they are important. So it's better to even know before they become pregnant. So we thought it was a better idea. So that's what happened. So every Sunday they will do that, and they will identify those, and they will ask them if they want to enroll in the Healthy Beginning Initiative. That this was a church program to support the pregnant woman during the pregnancy and throughout her delivery. Then they will schedule for a baby shower. So the baby shower will happen. So they will do this, and once every month they will do a baby shower. And in the baby shower is basically what we did also that was different is that when we had focus group before, I'm abridging a little bit. So there were a lot of focus group with the women, with the church, and in developing this program. One of the things they were talking about is that, people keep talking about HIV as if it is the only problem we have. So our question to them is, what other problems are important to you? So people say, well, sickle cell, for example, 25% of Nigerians have sickle cell trait. So that's the largest, and they have about 150,000 children born with sickle cell each year in Nigeria. 80% of them die before age 5. So this was a big problem. You can think that, compare that to the 51,000 born with HIV, the 150,000 with sickle cell. So we thought it was an important thing to them, so we included that. Then we found out something that was surprising, is that almost everybody in our focus group knew somebody that died from hepatitis. So we included that. Of course, malaria was an issue, so we included that. And so those were the three major things we did. It was HIV, hepatitis B, sickle cell were the three main ones. We included other things just to make it a healthy beginning. So we added sickle cell, and then we now started asking the church during the baby shower, they can do training, educational program, and they can include whatever they want to talk about, as long as they include discussion about these diseases. It was important, yes.
With the sickle cell, what can you do a pregnant woman
Early diagnosis, because the reason most of them were dying was something that was prevented, is late diagnosis. So if they know the child is going to have sickle cell, you will find out that the biggest thing that you can do is, once you diagnose early, is immunization again and penicillin prophylaxis. The same thing we do here that people don't die. Yes. The same type of thing, yes. So it's the same thing. And the penicillin actually happens to be one of the cheapest drugs you could buy in this area. So, but the problem is that the first time, and I can tell you when we started doing this, the diagnosis for sickle cell happens when the child come in and die. Actually, sometimes that's when the parents find out about they are carriers. It's when they have a child who have sickle cell who dies, and they find out they'll have a carrier. So there was none of this. Nigeria has tried to change a lot, because now some of the churches and the religious center insist on seeing your HIV testing and your sickle cell before you get married, and they say they don't use it for deciding who to wed and who not to wed, but that they think it's a fair disclosure to people. So we thought it was fine as long as they don't use it to decide who they wed and who gets married or not. But and you see some of the challenges that they do it too late, that people already printed their wedding card and they're not going to cancel it because they have sickle cell trait. But that's some of the things that happen in those. So you see how we integrated that. The integration of this other screening actually will reduce the stigma, such that if you actually went to those programs and say, I'm looking for the HIV program, they'll say, oh, not this one. They'll point you to another place. They didn't see this as a HIV program, which was good for us in terms of integrating that. And one of the things you find out people integrated, as we allow them to evolve, we kept a little room for them to be able to add things. So they will talk about breastfeeding. So sometimes we go to a baby shower program, and the older women are teaching the women how to breastfeed, and some of them were talking about nutrition, about what should you eat when you're pregnant, and we're fine. I will tell you one thing we find that was surprising, that the men, when we have our focus group there, the biggest thing that the men wanted to find out was their blood level. And you ask me, why would a man want to find out his hemoglobin level? And the men said, the women think we are weak, so we need to show them that our blood is good. So we actually added hemoglobin to that for the men, and it was surprising to tell you. So let me tell you this. Let me tell you this. I can tell you very strongly that the reason the men came back to check their result was hemoglobin. They came back to find that result so they can go back to their wife and say, you see, leave me alone, I'm healthy and I'm strong. They actually don't come back because of the HIV to see the result. They come back specifically for so it was an important thing.
Yeah. So just a quick question. So with the baby shower, or even with the reception, were any vaccinations offered on site, or were you checking?
No, we didn't do because that wasn't our focus, but that will tell you how this infrastructure can become. I remember the CDC director going over there to see this program, and he made two statements. He said, if I wanted to do prostate screening, I can't find a better place because of the men that were there and finding the men. And the second thing he said, can we use this for start our birth hepatitis B vaccination, which was our baby reception. So you see what other things we've been able to try to do with this infrastructure. So you have those three things. What we did, the prayer session helped you to identify the pregnant woman early. It helps you to have, because if you identify them early, then you have multiple opportunity for them to do this. And because this became a very general thing, what we found out is that even when people come for the baby shower, they become friends. If one of them deliver, they still come to support the other one doing her own thing. So it became more like a little bit of a social gathering, and you look at that. The baby shower allows us to put this intervention in place. So I remember going there with the USAID director that was in Nigeria, and he got in here and people were dancing. So he said, so where is your intervention? Where you screen them? I said, look behind you. And he turned back, and there was, so when you come in, you register for the baby shower, you get your blood draw, and you join the baby dancing. So that was the attraction here, but behind that was what we were doing, but it wasn't, the people weren't coming here because their blood was going to be done. We are saying, for coming here to join this, we're also offering you this test free. So you can imagine what will happen then. So that's the thing. And then we bring them back during the baby reception, and then it is the same thing. It helped us to look at newborn testing, but also the fact that the biggest problem for those, you have seen this, I think is the same in areas where you work, is that pregnant women will adhere to the antiretroviral therapy until they deliver. And once they deliver, the dropout rate is huge. After delivery, and that's one of the things we think that will be another point for linkage to care after delivery. So those were the three infrastructure that we had.
So can I just ask you a quick question?
Yes.
Do you think that there were populations that may be more likely to be missed, like unwed mothers or adolescent mothers, and how are that?
So we thought so, but there is something actually we didn't realize, which is I think I forgot to do it. I forgot to show you. I wanted to show you in the video, but I will speak to it. Is that one of the things we did was we have a mama pack. So mama pack they had in Nigeria. In this mama pack in Nigeria, they used to give it only to people who are HIV infected. And we felt, how would you feel if you're carrying a bag that is only given to people with HIV infection? Nobody's going to carry it. So we say, well, why don't we give it to every woman? And we actually had a focus group to say, what is it that you want to see in this bag? Recognizing that only about 35% of them deliver in the hospital. It was basic things like a sanitary pad. It was basic things like a clean razor blade. It was basic things like alcohol swab. One thing that everybody asked for that we put there was olive oil. I don't know what it does, but they use it to wash the baby, I think, and then they use it to pray. So we added that. So we also add each of the churches to be flexible what they have in the bag. But most of them had these basic things in the bag. The other thing we changed is that during the baby shower, those presents are not given to the women. This was actually changed by one of our team who recognized that initially what we have planned is that after the prayer, the priest will take the present and give to the woman. But he said, well, why don't you just change a little, give it to the man, understanding the culture, and let the man give it to her wife as a present. You can imagine, and you will see what he did to our male participation. Because now you will see the priests, some of the funny priests, and a lot of them actually, the ones that were married, their wife passed through this program. But you will see them say, oh, we are going to have our baby shower this month. If your husband is not here, I give you 5 minutes to call him. Okay, the priests were also happy that the men were being drawn to church. So everybody was happy. And you see some men rushing in there, buttoning their gate, because you see the women say, you better come here to give me a present or no food for you tonight. So that was one of the things that we found out that even the unwed mothers will come for that. That was also an important part of what was successful in drawing out people who otherwise would not. You wouldn't think that would, but it did. But the other thing it did also, it did also make some people go to 2 churches to collect 2 of it. So it had its own positive and the challenging part of it. But that was something that we found that was there. So this is really the infrastructure, really, because I think what I'm going to show you is what really happened in the baby shower. But if you had any question, this will be the infrastructure we had, the framework we had. Our hope was that we have a framework that can identify women early. We have a framework that apply an intervention, because at this time we started thinking more about beyond HIV and all the things. I can show you some of the things we're doing there in terms of chronic disease, because this become a health fair. So now we actually get blood pressures. Now we actually get blood sugars. Now we actually do breast self-examination. There are so many other things that because you have these people here. So we've done a screening for perinatal depression. So there were other things that we have added to it. So this is really the infrastructure. We had already 1,000 people recruited, because we said we were going to recruit 3,000 pregnant women and their male partners. This was our grant was the funniest kind of RO1 that was 2 years instead of 5 years. So they wanted result in 2 years. So I was like, how are we going to recruit 6,000 people? So, but it was funny. The first time we went to this, we had gone and asked all the churches to give us the list of infant baptism the last year. And we used that to estimate how many pregnant women will be in the church. So in one of the places, they had about 20. So we went there with 30 and think maybe there are more people who have pregnant. We went there were 100 people. The next one that gave us 20, we said, okay, let's go now 50, because of maybe that one was a mistake. We went there were 150 people. So for the first time we started, there were many people that were happy with us, because they will stay. We don't have the tools, we don't have all the things we are gone.
Do you have a sense of, how many women who identified themselves at the prayer session ended up delivering a baby?
Yes, we actually do, because I can tell you from all the people we recruited, we lost almost 156 babies. About 5% of the women lost their babies.
Prior to delivery?
At the end. So some of them were prior, some of them were immediately after, before the baby reception.
And that includes women who just said they were pregnant, but you don't know if they're
Well,
pregnant.
there was no way to know that.
Right.
So that was included. That
156
yes,
is
included
small.
that.
Okay.
Yes. So again, we removed our pregnancy test, which was initially part of our application, but we felt that the money for the pregnancy test, if a woman came out there believing she's pregnant, she must be pregnant. We didn't find any 65, 80-year-old woman coming out. So they were all in the, so we said if they screen, if they come out and get screened, good.
It's pretty amazing because that
Yeah.
means that like 90, if my math's right, about 94% of the women who said they were pregnant went on to have a delivery. That's
Yes,
amazing.
you will see that in the result. So this was really our specific aim for the study. It was just straightforward and simple. What we wanted to look at is to have 40 churches. We divided them into two, 20 churches and 20 churches in intervention and control. It was not usual care per se, so because there was a lot of discussion and a lot of the fact that we are going to do almost the same thing in intervention. So it was a kind of enhanced control. So we believe that the rate of testing in our control was going to be higher than the rate in general public. But what we said is that no matter what the rate is in our control, that our intervention will be higher than that by 20%. So that was how we said it. What we wanted to do in the control, what we did was actually to do the same three infrastructure we did. The only difference is that during the baby shower, there was no testing, there was no education, which were the only two things we took away. But there was a direction for them to go to the hospital and get tested. So we know that that alone will also change what the control is. So, but we said no matter what the control is, that we want to compare whether that intervention will lead to a higher HIV testing among the pregnant women, HIV testing among the male partner, and linkage to care among those who are HIV infected. So these were our three aims for the study.
So in the control arm, you did the same thing where you identified pregnant women?
We identified pregnant women. That's the only way we registered them. We also had a baby shower for them. The only thing is that there was no test offered and there was no education about the test offered. We sent them to the hospital. We also had a baby reception for them so we can capture and see how many of them got tested in this way. So those were the three infrastructure, yes.
You're saying that you had clinical staff come to the hospitals to provide the tests?
It wasn't really, I don't know whether you call them clinical staff as much as we call them what they call CSS, community specialists. So these are the PEPFAR supported program that runs the clinical side, have people who go out and do community testing for them, which I will tell you a little bit now. Most of them are adopting this as a way now to do their community testing. So what we did, instead of them going to all those community testing, we asked them to come on Sundays to run the baby shower for us. So they were there to do the testing. And then also once identify somebody, that's also in their program. It did change one of the things we did in our research. So we had some funding to hire research assistant, and as we began to see this early, we didn't actually hire research assistant in all the churches. What we did was to set up health teams in each of the churches. So we set up in each of the churches that was participating, they must have a health team. A health team includes the priest, includes the leader of the men group, includes the leader of the female group, and then include two people we call church-based health advisors. So that's what the health team found. So what we did was actually to use the two health advisors to actually run this program. And as we saw this program become successful, we actually changed in terms of one of the health advisors we now trained to be a phlebotomist. And there were some problems because I didn't realize that people, there were the laboratory scientists in Nigeria were against us training lay people to do phlebotomy. And I said, even if all of you become phlebotomy, there weren't enough of you. So until I actually told them that. So what we did was to go to a laboratory scientist school and ask them to do the training for us and train the lay people to do phlebotomy. Why not? So that they can, what we were hoping for, because it was 2 years, we were hoping to be able to leave and have something in place, which is why the foundation was actually founded, because we were supposed to do our recruitment for a year. In 6 months, we had our number. And we wanted to leave, and they said, oh, you said you were going to be here for 2 years. So that was some of our problem.
When you talk about the individuals at the church who were involved with the program, so
there is a priest. We have to get it. There's a
male
male leader and a female leader.
Set it at the church, right? Those are not new people.
No, those are the churches.
Yeah, they're the churches,
Yes,
right? So
yes.
Actually just integrating it.
Yes, they're just
So
together.
how people are new.
We wanted them to actually take ownership of it.
Mhm.
So initially there was 3 phases we went in this grant. So we brought in our health people to do it. So that was the first thing until we begin to recognize A, that we are going to get our numbers early, and A, that this was actually well accepted and could become an infrastructure. So we began to think about sustainability quite fast. So when we started thinking about, so initially it was those PEPFAR people coming in to do that. Then along the way, we started to train the health advisors to begin to do it so that, of course, when we pull out, that they can continue the program if they want to, because then they have all the infrastructures to do it. So that's what happened. And by the time we finally, like now, and I can tell you what is happening now in some of the places, those people can actually run this program. All the health programs do is to supply them the things they need and then come on that day to pick the results. Yeah.
One of the nice things also about putting it in a church is that people give donations to churches. They often have resources to buy things like consumables that people still need to buy in health facilities. So if there was a real motivation for the priest and the committee, they could continue this indefinitely.
Yes, that's the truth about it, and I will tell you some of the challenges that things sometimes don't work like that in Nigeria. But that was one of our thought process, and the other thing that we also, but there were some things they would do. I don't know if you remember the bishop that was in Nigeria, that was in Zimbabwe, that came with us. I think you remember the bishop that came. He was at the United Nations panel in Zimbabwe presenting this. But one of the things he has done is that after we left, he took the whole people that we discovered now, so they now form the community insurance program, and they're now the community insurance people. All these are so they actually now include this as part of their insurance provision. So if somebody wants to be innovative, there are things they can do with it, and if they want to sustain it, there are things they can do with it. But there are some of the challenges that we'll talk a little bit about. Yeah.
Can you just comment, was all of the linkage that you did with each individual church, or did you go through sort of the main Anglican church in Nigeria and the main Catholic church in Nigeria?
So we did at the first time we worked with 4 bishops. We went to 4 dioceses, 2 Catholic bishops, 2 Anglican bishops. Along the way, we included some Pentecostal. When we started the first time, because we were scared about getting 6,000 in a year, which we thought was impossible, we wanted where we can get. So, for example, we went to the bishop and we asked him when does he normally meet with the priest, and he tell us. So we go to the meeting, we provide the refreshment for their meeting, and that gives us an opportunity to talk to all the priests at the same time. So it was a lot of logistical issue. Instead of going to each priest to meet them there, one of the bishops, the one that came to Zimbabwe, became, the day we went to mention it to him, after we said it, he said, let me repeat what you said. And he said exactly what we wanted to do. So he actually became a champion for us. When we went for the training, he stayed there in the training. Of course, when the bishop stayed for the training, all the priests stayed, which is good, in terms of a way to get people to stay. So, and the other things we did towards the end that, if I remember, I'll tell you things like we did things people haven't done there. For example, when we finished the study, we went back to the same way and went to all the churches to present the result to them, which was something that each of them were like, really, nobody ever have done that in terms of studies there. So that's some of the things we try to kind of make it a more of a relationship with the community rather than just a research project. So this is what we got in those results. You can see we ended up getting those numbers in Sweden and compared that. So we knew, like we said, that in the control that our numbers was going to be higher than the 16% because we identified these pregnant women early and asked them to go into the hospital to get screened. So the testing rate in our control was 54, so it was nowhere near the 16. It was much more than the 16, which by itself was almost 3 times what they had on record. But also, if you look at intervention, we had 92% of the women tested there. Which to us was a little disappointing because we thought it was going to be 100%. And we will tell you a little bit about some of those 8% that we missed. Where those days we came in with 20 samples and there were 80 people there and they went and they didn't come back. And some of the challenges that we had with that in terms of that. So you look at it, you find out that women who went to the churches that implemented intervention were 12 times more likely or 11 times more likely to get tested compared to the women who went to the churches that were randomized to control. So this was our set time was that there would be a 20% difference. Here they were close to 35-40% difference between the intervention, knowing also that our control was even higher than so we thought we were happy with that result. this is the one that actually I found more interesting than the part of the woman. Is actually the male partner. In Nigeria, the male, I came here and traditionally in Nigerian culture, grew up, even though I lived my younger life in Rochester, New York, I grew up mostly in Nigeria. So the first time my wife was having a baby and they told me I have to go inside the room when she was having a baby, I said, hell no, that is not a Nigerian man. You should wait outside and they hand the baby over to you. So really, the men don't get involved after the woman becomes pregnant until the baby comes. So getting the men in, participate in anything, I will tell you, is challenging in most of Africa and even in Nigeria more, where the man is a dominant figure in the family and his role in his mind is to bring the money, and the rest of the things the woman have to take care of. So getting the men to antenatal care, I mean, he wouldn't have worked with me, and expecting it was a little bit difficult in Nigeria. They've tried things like love letters, but for them different things to try to get them work. But so we were surprised that we have a male participation rate of 83%. I don't think I've seen any other study that had this number of men, male partners participate in any study. So we were very happy with it. But also, if you look in the testing rates, you look at the control, where it was 38%. Again, this is way more than the Nigeria male partner testing was closer to 10 or 5%, because where there wasn't a place to find them, they don't come to the prenatal care. So the 38% in the control was actually huge already in the control, because remember, in the control, they still came because they have to present the present to their wife. It's just that the test wasn't available to them. That was the only difference. So they came there. So, but if you look at intervention, we have 86% of the men testing, close to 90. That's close to 50% difference between the control and the intervention. So it tells you again that that will probably the one chance you see the man, and if you take it, that you will actually. So again, it confirmed what we've always known, that when HIV is offered, that they don't reject it. It's just that how do you get them and where do you provide this testing? That was the biggest problem. So again, here you see, like in the women, that the difference here was actually higher than in the women, and that also you see here that male partners in churches who were randomized to intervention were 12 times more likely to have been tested for HIV compared to the ones who went to the control churches. This is the third thing that we did, which was a very challenging part, but also opened our eyes to a lot of things that we are trying to deal with in Nigeria right now. One of the things we talked about is that we used the estimate that was provided by the government from the local areas in terms of HIV prevalence to calculate our sample size number. So what we had hoped is that to be able to answer the third aim, that we will have about 70 women that are infected in both arms, and we can compare the linkage to care. When we went there, because of the rate that we had, we did not get 70 HIV infected women in any of those places, and so we really couldn't compare this equally, because we didn't have our sample size. But you can also see the trend here that is also more likely that in the intervention compared to the control, that you do have individuals, women that were HIV positive in the intervention, where we got only 41, and in control where we got 32. So both of them fell short of the 70 that we needed statistically to say for sure that this is there. But also tells us a lot of the rates weren't what they were. We could almost, we got so many, almost all the women in the community, because this was really very popular in the community. So we felt we got all the pregnant women, and the rates we are getting weren't the rates that the government had. And we have, so far now, we have repeated this in 3 places now, and we're finding out the same thing, that the rate that we actually getting in this community population-based testings, we are less than what the government were getting. Again, because of the government, we are focusing on health facility, where you have a selection bias. And now in the new government surveillance thing, they're now including community sites like ours to actually come up the rate. So you see some of the rate dropping in Nigeria. We don't know what's driving that. This is, again, we'll tell you, remember what I mentioned, that in Nigeria, that the early infant diagnosis was was 4%. Here we have 2,400 women that were screened. We had 72, so our rate here was 3%. The government rate was 5.6%. So 97% of the people were negative. The 69 HIV-exposed infant that we actually were able to test, that these were the ones who were born and were tested. And 71% of them actually got tested. 43 of them, 88% was by early infant diagnosis. Again, this was because of our linkage to the baby reception, and then that being about the same time that they came for the baby reception, which we saw in the video. Then we were able to to actually get that. What we had was about 4% of the, about 4 of them, 8.2% of those who screened were HIV positive. So we did have 4 people that were HIV positive. Again, there was no way to know whether they were infected during delivery, whether our intervention failed or one of those. For sure, we are a couple that were HIV positive, and we went to them, and then they were supposed to go to the hospital to register. They agreed. They took them by car, and on the way they said they wanted to use, they wanted to pee. They got out of the car and they ran into the bush, and so this wasn't. It wasn't all roses. There was a lot of, people. We finally found out both of them were infected, and the drugs were free. Things were available for them, and they just ran away. So we talked about test and treat. Sometimes you see test and run,
So, sorry, just a sort of logistical question. So
Yes.
the children, or the mothers and the fathers and the children born in the intervention arm were being tested sort of, and the data were being collected right there. The ones who were referred, they were referred to the PEPFAR program, so you had access to the data through the PEPFAR program?
Yes.
Okay.
So all of them were referred to the PEPFAR program, both intervention and control. They were all referred because we weren't providing the other prenatal care. So everybody was referred to the only thing is that in intervention, it was also here for you.
But the HIV test was available there?
It was there, but it wasn't also the HIV test alone.
Yes.
Remember, so there was the hemoglobin, there was the sickle cell. So that also was helpful to us because you will remember the baby reception, because if it wasn't for the integration, then in the baby reception, we'll only be testing infants who were born to HIV-infected mothers, so you'll be singling them out. But in this case, we will tell you a little thing where we are trying now to use to put a newborn screening program for sickle cell, which is something I'll be happy to talk about today. What we're trying to use this infrastructure for that. But we also started testing those children who were born to women with AS, knowing that the only way a child can have sickle cell is if the mother is AS. If the mother is AA, no matter who the father is, that child cannot have sickle cell. So we also offered testing for sickle cell for children born to, so that kind of diluted just singling out those ones who are HIV infected. So again, like I said, stigma is quite a big barrier to successful implementation in Nigeria. And this is not just with HIV.
You said something about the ART use in
Yes.
the slides,
Yes.
and the HIV in the infants, but were those data not linked to the
Yes, it was linked. It was linked. It was linked when you're talking about those ART. There was actually all the 3 of them were positive, were women who received ART. Only one that was infected was one who ran away. So that's why I said we couldn't tell whether they were already infected or whether the ART failed. There wasn't a way for us to know that. But 3 of those who were infected were women who did receive ART. Only one was one who did not receive any intervention. The other question? Yes. We have that. We didn't have that here. I didn't put that here, but that information is actually, the publication should be coming out soon, because what we did have on Lancet was global was on the women, but we do have linkage and things. So what I presented to you, even on the men testing, the second slide is not yet published, so it should be soon, and on that we have this information for the men. Yeah. So of course I said, this is not a program that were without challenges. There was a lot of challenges. From the first time there was a lot of skepticism from the community. And one of the things we did was really to establish a model church. So we come into a place, we put on one site and we do the program there, and then the word spreads, and then the people start asking their priest about that this church is doing a program to support their women. Why are not doing that? So adoption became a little bit, so have we tried to, ramp up, which we wanted to do because we had only a 2-year grant. We wanted to start it over, but it was just skepticism. So we went out to this model, and they actually helped the adoption go fast. By the time we ended this study, we had 200 churches instead of 40. So it will tell you what happened. Yeah. So, yes.
How many are still going?
So we did our first year after we stopped review. That's one of the things. I was in Nigeria in July. Because we have 2 more grants there now. So I went over to the churches. We transited the churches from the first one. The first thing we did, remember what I told you, is that it was the program that was coming to do this program. So while they were coming to do it, all the churches continued. Then we got to the second phase where we started to provide them with the support and for them to do it. And at this time, close to 90% of them continued it. In the last year now, we withdrew that and wanted to see how many we sustained. So I would let you know in about a year how many that was. But these are the different times. So when we continued, we go in there to support and run the baby shower. Everybody continued it. They loved it. When we pulled back and asked the health team to run it, but we provide the supplies, 95% of them were still continuing it. The ones that didn't continue it is because the person that was trained to do the phlebotomy left and moved somewhere else, and there wasn't nobody else who could collect the blood. That's why they didn't do it. They wanted to do the baby shower, but we wanted the testing also to accompany that. The third part we did now is to pull back completely and ask them to support it, like your hypothesis. So we'll see.
But even when you provide only supplies, you weren't paying people.
No, we did not pay. We did not pay people for salaries. We never paid people even in our study. What we did in our study is that we gone back and gave 100 naira, which was at the time was about $1. Now it's about 50 cents, to the woman per woman that went through all the process and came to the baby reception, to the church. And we didn't give that to the woman, we gave it to the church as a church. So at the end of the day, we did buy a computer for the churches that participated, and then we put their own result on that for them to continue, looking at sustainability and things like that. So there was nobody that was really paid except our research coordinators that went around to do this. Again, we were thinking about paying people in our own mind wasn't really going to be a sustainable intervention. And sustainability was really one of the things we were trying to look, because we think that if we succeed, that this could be used for much more than HIV in our own mind.
When you transition from the PEPFAR supported clinical people doing it to the health advisors within the church,
yes.
Are there any issues with the people within the church knowing the status of their congregation members and confidentiality risks?
So, very good question. So one of the things we did differently is also we did not use a rapid on-site testing. We collected blood and it was run in the lab. The reason we did that is a couple of things. So A was for this question that you asked, but also secondly because we wanted to draw blood for the testing, sickle cell, and we didn't want to do the oral one. So if we were going to collect blood, and we became confident that we will find this woman, that we weren't worried about going to test and bringing back result, which you do worry about if you are doing this in another community setting. This is really why the church is people tend to go to the same church for as long as they live in this community. They actually don't change. It was surprising to me how these are usually community-built churches. So they built this, they identify with this church, and we were in the rural area, so there wasn't a lot of people have been going to this church that's where their mother went to, that's where their grandmother went to since church ever came to the area. So we were very comfortable with taking the blood testing and bringing back results. It solved the two problems that you were worried about.
And then the result, who gives them the result?
So again, we have a new project, and I'll tell you some of the things we're doing in the new project. But in the continuation of the things, they will ask them how they want their result. So do you mind your church people telling you about the result, or do you want the program to tell you the result?
And what do people say?
Actually, they were diverse. There were people that said, "We don't care." There are people that said, "I want the people to tell me." Initially, which could have been a research study by itself if we had a student that was, because by this time we were having multiple things now being built into this infrastructure, that part of it get lost. But in this new one now, we actually put in that now. We're now trying to find out specifically what people will pick, because it's going to be an important part in terms of sustainability of these health teams in churches in doing these programs. Yes.
I just have a question. So this is being done in churches. Is there much of a Muslim population?
There is a lot of Muslim populations in the country, but the country is divided essentially as if you've been to Nigeria, almost like two countries. So if you go down to the south where we were, it was almost like 95% Christian. If you go to the north, you'll be about 80% Muslim. But one of the grants that I hope we want to do, that's one of the things her and I have been talking about, is a way to adapt this to the Muslim population. We have the population in Nigeria. One of the things we wanted was to do an out-21, do a focus group, see how we can adapt that. You will need adaptation to do in the church because of two things. A, the men and women don't worship together in the Muslim. Secondly, I don't think you get any Muslim woman kissing the husband in public. So there were two things that are different. So by what we were trying to do, if you make it an only woman program, you can adapt it in the mosque. But if you wanted to make it a couple program, then there will be some adaptation. We may end up being done as a women-only program and then as a man-only program. So there might be two parallel programs running in the mosque. But that's a thing that we could do. We have both the population.
And also the polygamy difference, I guess.
Well, the polygamy is not limited to the Muslims in Nigeria. The Christians also do have polygamy. It's less in the east where we are. Again, polygamy in Nigeria, depending on the hypothesis, in the south is an economic issue. So as economy stresses, most people started marrying one wife because two was expensive. So things in the south, you don't see a lot of polygamy, but again, it's not uncustomary. It's just that it's an economic realization by the southern part of the country that you have to take care of yourself and one wife before you get married to the second one.
Two quick questions. So which state were you working
So initially we were in Enugu State, which was in southeast. In the new study we have now, we're in Benue State, which is in the north central.
Yeah. And then in terms of the blood samples, how were they transported back to the lab, and were you supporting that, and what will happen with that?
So the first part of the program, when we came in, it was a PEPFAR program, so they take their blood to their program. There was no problem at all. In the second part, they will come on Sundays to collect it from the churches after they finish. So we support it. Part of our grant funding was that you must have a PEPFAR supported partner. I think it was also on your grant. You have to have a PEPFAR supported partner to write the grant. Was it a requirement on yours?
I'm not sure if I have that.
Oh, it was a part of. Didn't you have someone in Canada he was on the grant that we specifically on the grant.
But who was it? Oh, no.
I mean, the whole MS.
Yeah, it's all
Yeah, I guess if we're doing it within a hospital.
Yes. Okay. The program. So yeah. PEPFAR supported. So yeah, all it did was a PEPFAR supported, and in most of these countries, almost everything is PEPFAR supported these days. So that was there. Now that we pulled out a little bit, that's why I'm telling you that we're going to find out what's happened.
Yeah.
When we supported in terms of going to do it, it was close to 100 of them. 100, not close, 100% of them continued. When we transitioned to them doing it and then supplying it, it was about 95%. Now we completely pulled out in the third year, and I will tell you what happened. Yeah. But that's a project. If you have anybody interested in it, we will, as a project for PhD students. I'm overwhelmed with a lot of projects going on there, so I'm open to anybody that wants to take it as a PhD project. That's what I do now. So that it was an interesting thing that we'll look, and they can look at the 3-year sustainability of this program. Yeah.
I was interested also, like, you made a lot of really careful decisions about which tests and how long you would follow the baby.
Yes.
So you could imagine using it for kind of a centering program where these mothers take care of each other through early childhood or
Yes.
do many different things.
Yes.
But people will always come up with more things you could add to it.
Yes.
And so every time, how do you make the decision? It's just kind of like it's almost like a cost benefit and a focus.
We had a focus group. Again, what we wanted to do, and this is for me, I'm from Nigeria, so there was the look at me for, right now, for example, in the part of Enugu where we did our study, you can't get any research study done there unless they ask me to say if it was okay for them. So that will tell you the kind of trust burden that they put on me. So they asked me, so what do you think? Should we participate in this? So I have to be careful again in what I introduce to them. I have to go in there, do pros and cons for the community that have come to trust me. It's not a burden that I really want, but one that I have to if we're going to come back to do anything there, to make sure that they felt that their community interest, that I took interest in it. So that was some of the things. So we asked them, this is one, and I'll tell you the things we've added in the next slides, and I'll tell you how we made those decisions. I can move through them in terms of, I put them there just in terms of, but I'll just show you one slide, because we do have that. So look at the hepatitis B. If you look at the HIV among women is 3.3%, among the men 1.9. Look at the hepatitis B, among the women is 4.5, among the men is 6.2. Of course, the sickle cell came to what we thought about. 23% of the population have that. So again, these are important to look at what is it that is important. So in our other programs, this is now what we try to focus around. For example, we did syphilis, and what we find out that, yes.
Is that surface antigen positive?
Yes.
Okay, so they actually have
Yes.
chronic active.
Yes. We don't have the core and that it was just surface antigen, so we don't know if they overcare, how's it there? Well, if you actually remove it, the hepatitis B surface antigen won't be there. So these are people who actually did have it. One thing to mention is that in Nigeria, actually, that liver cancer is now the #1 cause of cancer mortality in Nigeria. And a lot of that is from, of course, you know that if you do get the transmission early in your life, 90% go to chronic hepatitis B. So if you ask me, this is one area that is important. If I actually go back, and if I do, the hepatitis B is one of the things I think on the primary care level that I talk. So as I talk to your people, I want you to think polio plus instead of just polio. And then think about how we can use the same infrastructure for other things. Hepatitis B, yes, because we don't see the effect immediately, we don't see the paralysis immediately, but think about it as a #1 cause of cancer mortality down the road, and it's preventable. Yeah. So these are the things we've tried to do. Like I said, we try to make our intervention feasible, culturally acceptable, sustainable, and in some way different from how they do things there. The framework that we have make it family centered. We try to make it have a lasting impact in the community. We have now adapted that, so we use that now for mental health screening. We look at for perinatal screening. We do that for newborn screening program. We have for sickle cell. We do have 2 other NIH grants down looking at the 90. The first part we did on the baby shower was the 90, which is screening. So now we are looking at retention. Our hypothesis in the retention is that if we test them in the church where we know where they are and link them, if they get lost to follow up, that we can find them back. So we're looking at a network intervention between the church and health facility. And that's another project that we have down there. And another thing that we're actually looking about is that if we take those 3 results, hepatitis B, HIV result, and we're able to have them and actually make them available at the point of care for the physician, how does that impact how many of the babies that they get, they start on early things, hepatitis B, how many of them get vaccinated, and the sickle cell, how many of them got the penicillin prophylaxis. So again, that's another project. We had an R21, an R01 for that would be nice. So that's what is next for Nigeria that we're trying to do at each of these points. Now we have a project working to look at the 90, and all of them are still using the infrastructure, which we've now gone to a community health facility-based intervention. This is just to say thank you to a lot of the people that do help us do this, and that this project was funded by NIH. I do have a very dedicated group in Las Vegas that have. All of them have been to Nigeria at least 5 times, and they actually love this project so much. And that's the foundation that we put in there, just because when we tried to leave after the 6 months, we couldn't. And we started this. One of the things we actually did was we solicit for baby blankets and baby hats to support them for the baby reception. So that when they have the baby reception, that was what was in the gift bag, because it was not part of it. So if you come back with your baby, they have a receiving blanket and the baby hat and things like that, and that's some of the things we support them. Well, thank you. Sorry I went over time,
No,
but
fantastic.
Thank you.
thank you. Thank you.
Maybe just a couple minutes for questions, if there are any.
Yes.
Quick question, you briefly mentioned syphilis screening.
Yes, yeah, I mentioned syphilis screening, but it was because it was very surprising to us. We tested almost close to 6,000 people. We only found 7. So one of the things that I'm pushing for, and that I hope I'm going to try to do in the primary care agency, it maybe is to redirect that funding for syphilis to hepatitis B. But there is a question: did we see less of it because we were testing and treating? So was that a success story? So more like you say, now we're no longer seeing polio, and it was all because we vaccinated. So if you stop it, what happens? So that has to be looked at carefully, whether that we didn't sign a number was because syphilis is generally not a problem anymore as much, or because it has been a successful program that should be kept. So it's a but then when you are faced with very limited resources, when you are screening people for syphilis, you find 1% of them, and you are not screening for hepatitis B, that is close to 5%. It's a public health question. I don't know the answer.
Is it standard, Hep B vaccine standard?
You see, it is now. It is now. It wasn't for a long time. Think about it. When you introduce new vaccines in the U.S., it takes about 10 years to get to most of the
No, so
African
it's part
countries.
of the schedule.
But it's part of the schedule now. Yeah.
So if they had gone to MCH, they would all get it.
Well, the babies?
The babies.
Yes, but you remember also the babies will get it. So now that's why this is important, that if we actually can use this to increase that, in a couple of, within one generation, I would say, but in a couple of years, we can actually, I would like to have a national plan to eliminate perinatal transmission of hepatitis B. I think it's part of what the primary care should do, and if I'm there, it's one of the things I'm going to push for is a national program for elimination of perinatal hepatitis B transmission. I think it's doable. I think it can be done very fast. I will integrate it into the HIV program and have all these women vaccinated during the HIV program, doing the testing. I will have the babies get it. The country pays for it. So I think it's one of the things we can actually achieve. It may not be as popular as polio, but I think it's an important one.
And one of the things that I'm really happy to see with what you did with this program was because it was client focused, you did the focus groups, you identified the best ways to interact with the population. One of the challenges that the program has had has been the quality of care at clinics, that the families have not trusted the care, they've not, even though perhaps the vaccines are there now, people are still not coming to get their children vaccinated, and so using some methods like this would be quite
Yeah, we have to think, that's why I was telling you that what I was going to do is to go to University of Washington, go to Duke, go to Harvard, and beg them to send me one of their brightest students, and maybe if I sit down with them 1 year that I'm leading this agency, maybe they'll make me brighter, and we'll find some solution. There have to be a different way of thinking to do this. It has to be different. The first thing I think about is people talk about primary healthcare system in Nigeria as if it only applies to those who go to government hospital. But private hospitals that deliver primary care are primary care health centers, even though they're not government owned. The churches in Nigeria a lot of them have health facilities. Actually, in Benue State, we're working now. We're working in almost 30 facilities that are all provide primary care, all owned by the churches. They are all primary care facilities, even though they are not regarded as such. So again, to broaden what the primary health care means and who provides it in Nigeria, that is government, is private, is churches, and bring them under into this and try to look at programs like this, because while they may not go to the government side to get the immunization, they may go to this program to get it. So looking at some of those things.
One thought about that. So one of the reasons for those of you who aren't from UW that we invited you to come, obviously, is that we want to learn from your experience. We have a program, there's a brochure there, with the Orthodox Church in Ethiopia, very much focused similarly. And so I guess, for you, one of the questions I would have is, what do you envision are the pillars of the framework that are translatable cross-culturally to other religious groups or other settings? You talked a little bit about the Muslim community.
Yes.
So I think what we struggle is figuring out what are the core components
Yes.
that need to be there to ensure success, and what are adaptable elements,
Yes.
without being too vague that
Too
it's not
vague.
useful.
Yeah. So the three infrastructure that is there is really what I think you should do. It should be focused on a way that the people see it as supporting the pregnant woman. If you see that, so you have the prayer session, you have the baby shower, you have the baby reception. That infrastructure gives you the core thing that you need. It gives you a way to identify the pregnant woman early. It gives you a platform to implement intervention, whatever it is. It gives you a way to follow up. That already is part of the system. So the prayers, is part of the system. They don't change. And the prayer can be mosque prayer. Doesn't have to be Christian. It doesn't have. It's really not a church-based program. You could have done the only other place you could have done anything like this would be schools, but schools have age limits. So the church is more community-based, which is another place we did. So if you had these three infrastructure, I think you can adapt it anywhere. Actually, we are trying to use that in the U.S. here, in the new Mexican population in our state. So we already have that in the new churches here. So now, who said it can be used here in the U.S.? So that part of it is constant, and that's really what we look at as the framework. What you adapt or what you put in part of it now depends on where you are and what you do. In any church in Africa, I can tell you, church attendance in Africa is huge across all the countries. One of the things we had talked about was actually to look at a dissemination project to take this across the African continent with 2 countries from West Africa, 2 from East Africa, 2 from Central Africa, and run a multi-country dissemination and see. With the same way you're asking me what should be constant, this should be constant. What diseases they integrate should be depending on what happens there, as long as they have HIV plus. So that is an adaptable one. If you go there and they don't have hepatitis B, where there's no need to put it there, you can put it. But also you can use it for TB screening. You can adapt those part of it as adaptable, like we did. I mean, in this program we talked about infant feeding, we talked about breastfeeding. We actually just got a supplement to look at breastfeeding using this and the intervention on a program we call the Men's Club, which we find those men and actually looking at the role of the male partner in a breastfeeding. Everybody don't talk about the male partner, but they actually drive a lot of things. We use this to look at contraception. What impact do the male partner have on the choice to use contraception, but also on the choice of contraception to use? So the infrastructure that is constant is the framework. Is that the Healthy Beginning framework is not a HIV program, it's not a HIV intervention, but it's a program, it's infrastructure that allows you to identify pregnant women early, implement an intervention, and follow up. So that's how I will look at it in whatever thing that you want to adapt to it.
Thank you.
Yeah.
Well, thank you so much.
Thank
This
you.
is fantastic. What a great, inspiring talk.
Thank you for having me.
Thank you.